Okay, welcome to the second video, and in this one we're going to talk about looking at a chest x-ray and having a systematic way for doing it. Now, the way that I learned it when I was in medical school was to do ABCDE, but I like this approach, which comes from lifeinthefastlane.com, which if you haven't seen this site, it's amazing. It has everything on it. And they use something called doctors, DRS, ABCDE. So we're going to go through all of these elements here. Details, a ripe image, meaning like a ripe mango that's perfect. You want to have an x-ray that's perfect. And then soft tissues and bones, airways, breathing, circulation, diaphragm, and extras. So let's go through this. So the first thing you want to do is look at the details of the films. Now, in the old days, when we used to actually have actual films that were not attached to the patient's electronic medical record, it was easy to mix them up. So you would make sure that you looked at the name and the date on the film. So it's still a good practice to do, but hopefully now in the medical record, when you are in a chart, you will only see this person's film. Next, you want to see that you have a ripe image, and that stands for rotation, inspiration, picture, and exposure. So let's go through all of those. So rotation, you want to make sure that the patient is not rotated. And the way we'll do that is we'll use the spinous processes as representing the middle of the film, and the clavicles the ends of the clavicles should be equidistant from the spinous processes. So in this film, they're about equidistant. This one perhaps is a little bit longer, but for all intents and purposes, the rotation is fairly good. For eye, inspiration, you want to make sure that the patient took a good inspiration when they took the film, and you should see about 9 or 10 posterior ribs. So in this x-ray, we see about 11 posterior ribs. That's more than 9 to 10, so we have good inspiration. P stands for picture, and we want to make sure that we fit the entire chest on the picture. And so we can look for the costophrenic angles, and those both should be on the picture. Now, it might be that with big people, you might not be able to fit them on one image, and so a lot of times then what the technician will do is shoot 2 images so that they can catch all of it. And bonus points if the scapula are not overlying the lung fields. And the E stands for exposure, and that means that we should just be able to see the disc spaces in between the vertebral bodies here underneath the diaphragm. And I think that's true. Like if we trace these, you can barely see them, and that's exactly what we want, that you can barely see those intervertebral disc spaces. So now that we've looked at the details and we have a ripe film, now we can go on to looking at the rest. So the first thing we're going to look at is soft tissue and bones. You're going to want to look through all of the ribs to make sure there's no fractures in there and there's no lesions in there. You can look at the sternum, which is a little bit hard to see on here, but that's where it is. Make sure there's no fracture there. And then the soft tissue is all the skin and this area over here, where you might see subcutaneous air or other masses and things. You may also see breast shadows in women and calcification of the aorta in older people with atherosclerosis. And that is looking at the soft tissue and bones. Now let's look at A, airway and mediastinum. The trachea is usually going to be in the midline, or it might be slightly to the right as the aorta pushes it off to the right a little bit. You can look at the aortic knob. It should have a shape somewhat like this. When you have a thoracic aortic dissection, this might be widened. And the mediastinal width should be less than about 8 centimeters. In the old days, we just used to put our pager, which is about 8 centimeters, up on the mediastinum. And if it was bigger than our pager, then something was wrong. And of course, you could look for irregularities or fullness in the hilum, which you might see with heart failure. So those are really the elements of the airway and mediastinum that we're going to look at. Now, B stands for breathing, which means that we're going to look at the lung spaces. And so one thing you might want to do is look for vascularity. And you can see these very faint lines that are kind of going out to the side. And you can see them kind of going all throughout the lung. They're much thicker along the bottom and much thinner along the top. And that makes sense because gravity is pulling the fluid downward, and so you're going to have more fluid near the bottom. But you should see this getting up to the pleural edge. This should be about 2 to 3 centimeters away from the pleural edge at the top and about 2 from the bottom. Now, when you don't see those vascular markings, and what you just see is kind of like very smooth, homogeneous black space there, then you should start thinking about a pneumothorax. And the pneumothorax can be subtle, so it could be hard to see, so you really got to be looking for it. And you'll probably see it best in the apices, meaning near the top, because air is going to be pushed near the top because gravity is pulling the rest of the lung tissue downward. When you're looking at the breathing area, meaning the lungs, the other things you want to look for is if you can see the fissures. If you can see the horizontal and the oblique fissure on the right side, as well as the oblique on the right, because there may be fluid in the fissure in things such as heart failure, or pneumonias may stop at a fissure if you have a lobar pneumonia. And so I tried to imitate that here. You can see this fluffy looking stuff. This is an infiltrate, or what a pneumonia might look like, and I drew it here in the right upper lobe, so you can see it stops at the horizontal fissure. Also on here you can see that I've blunted these costophrenic angles, right? So before they were nice and sharp, and now they're not. They're blunted, which you're going to see when fluid collects in here with things such as pleural effusions, heart failure. Pneumonia can also cause this. So that got us pretty much through B, which looks at lung fields and pleura. Now let's look at C, which is circulation, heart position, borders, shape, and size. About 1/3 of the heart should be right of the midline, and 2/3 of it should be about left of the midline. Then we can look at heart size as well. And if we take the length of the chest, the length of the heart should be about half. So the cardiothoracic ratio should be equal to 1/2. We should also see clear, distinct cardiac borders. So like in this case, we lose the border here, right? So it's not as clear and distinct. So these are indistinct borders, and that might be a marker of some sort of infiltrate or pneumonia going on that is making the borders not distinct. Because remember, a pneumonia is water, it's pus, right? And the heart is water, blood. And so they're about the same density, and so you lose that distinction, whereas before you had an air to fluid border, which is very clear to see. Okay, so that gets us through circulation. Now we're on diaphragm. So remember that the right diaphragm is going to be higher than the left diaphragm. Underneath the left diaphragm, we're going to see the gastric bubble. They should have a nice smooth shape to them. And we want to make sure we don't see like a black stripe of air underneath the diaphragm, subdiaphragmatic air, which is a marker for pneumoperitoneum. So be on the lookout for the black stripe underneath the diaphragm. So that gets us to diaphragm, and the last thing we have to look at are the extras. And extras are other things that you might see. You might see an endotracheal tube, which has a radiopaque stripe so that we could see it on X-ray. We may also see things like an NG tube, which should be going down into the stomach. You may also see leads from the cardiac monitor, pacemakers and other devices, and other tubes like chest tubes. When you're looking at these things, make sure they are in the places you expect them to. Like if you see an NG tube, but it's heading off into the lung, that's obviously in the wrong place. Or as you can see, this ET tube is starting to veer off to the right. We want it to be above the carina, so this one needs to be fixed as well. So that's our mnemonic for a systematic approach to looking at a chest X-ray, and we use the one from Life at the Fast Lane. That is Doctors ABCDE. If you go into Life in the Fast Lane, which is LITFL, lifeinthefastlane.com, and search for ABCDE, I'm sure you will find this. And there's a lot more stuff on that site about this. All right, thank you for watching. Bye-bye.